champion worldwide. However, while performing endoscopic spine surgery, we should always keep in mind what is the ultimate goal of endoscopic spine surgery. As we can see in these pictures, it seems that the ultimate purpose of endoscopic spine surgery is to effectively treat the symptomatic pathology that causes symptoms while preserving the functional segment structure sufficiently. Endoscopic spine surgery has made a lot of progress over the years, and it has undergone transforaminal endoscopic lumbar discectomy and second generation of intraminal endoscopic lumbar discectomy and the third generation of endoscopic decompression surgery, and is now entering the era of endoscopic fusion surgery. However, it should be remembered that all this begins with the transforaminal endoscopic lumbar discectomy, and is also here as the ultimate rationale pursuit of endoscopic spine surgery located in transforaminal endoscopic lumbar discectomy. Historically, transforaminal endoscopic spine surgery can be said to have originated in 1986 when pelvis cambing introduced pelvis cambing triangle at here. However, visualized endoscopic spine surgery capable of full endoscopic spine surgery began in 2000 when Anthony Young introduced inside-out transforaminal endoscopic lumbar discectomy. In addition, when Thomas Hoogland introduced outside-in transforaminal endoscopic lumbar discectomy in 2005, transforaminal endoscopic spine surgery made a lot of progression. And now, through this mobile outside-in approach, all lumbar symptomatic discs can be solved by endoscopic spine surgery. Now we in the surgical consideration. Can you hear my sound?
Yes, we can. Yes.
Can you hear my sound?
Carry on.
Yeah, we hear you.
Can you hear my sound?
Yeah, we hear you.
We hear you. Kim, we hear you.
Yes. Sorry.
Kim, carry on. We can hear you.
Sorry. The approach of the transforaminal endoscopic lumbar discectomy divided into inside-out and outside-in approach. Inside-out can be easily applied even by beginners, but it is a useful method. It is a useful method in limited indications because manipulation to the target point is not easy. On the other hand, the outside-in approach has a learning curve, but it is a method that can be applied in a wide range because working channel manipulation can be easily performed. The major obstacles of transforaminal endoscopic spine surgery such as high canal compromise and high-grade migration, but these all bony structures. Now, with the development of endoscopic drills, most of them resolved. Another things to look out for in the transforaminal endoscopic spine approach is the transforaminal approach is that there are three different approach routes. There is an intervertebral route, which we generally applied, and foraminal route that can be used effectively for bilateral disc foraminal disc and the superior migration disc. And there is a suprapedicular route that can be used effectively for paracentral and inferior migratory discs. Also, be aware that using the mobile outside-in approach in the transforaminal approach allows we to approach the target point much more effectively. In the approach angle, it is recommended to maintain the approach angle from this 25 to 30 degrees to minimize the visceral injury and nerve root injury. After working channel is settled in the safety chemist triangle at here, we can lower the angle to the target point. Also, if we choose the disc type according to expert grade, we can increase the success rate of the surgery. Now let's look at the cases found in the transforaminal endoscopic lumbar discectomy. Here we can see the foraminal to superior migratory disc. Foraminal to superior migratory discs are often difficult in open surgery. However, in transforaminal endoscopic lumbar discectomy, if we use the foraminal route is used, damage to the surrounding structures can be minimized while resolving this problem like this. In the cases of high canal compromise, you can see here the high canal compromise. In these cases, neural retraction is inevitable in open surgery. So neurological damage will inevitably follows. However, a transforaminal approach, if it can possible, it can minimize such neurological damage and maximize the recovery of nerve damage without another structural damage. You can see here. And in open surgery as well as in transforaminal endoscopic spine surgery, you can see here the highly inferior migrated discs has always been a difficult challenges. However, the advancement of the surgical technology such as suprapedicular circumferential opening technique and the development of the instrument has made it possible to sufficiently solve these problems you can see here. If a large palatal disc rupture disc, if it happen, it is difficult to insert to the working channel due to it make a severe pain during the insertion of the working channel. Because of that, it can be effectively removed using floating technique like this. In the cases of recurrence after open lumbar discectomy, open surgery may lead to dural tears or neural damage due to adhesion. However, if we use the transforaminal lumbar discectomy, it can minimize this problem by using virgin route independent of the existing love route like here. High lumbar level HMP can cause nerve damage in open surgery. You can see here. So it is not easy to remove the region effectively. However, if we use the transforaminal endoscopic lumbar discectomy, it can be minimized these problems you can see here. And until now, the transforaminal approach has not been easily to remove the regions up to each deep site due to various factors. However, now, as seen in these cases, is the area that can be effectively solve the four corner pathology through a transfemoral approach. Let's look at the terminal endoscopic lumbar discectomy. Currently, full endoscopic discectomy can be approached for almost all lumbar discs. A transfemoral approach is possible in almost all any areas. Of course, transfemoral endoscopic approach is also possible in many cases of L5S1. But in the L5S1, transfemoral approach is also transfemoral approach has many limitations in accessing the target point. When some degenerative changes have progressed, it may be difficult to reach the target point through transfemoral approach. Fortunately, the L5S1 level has a wide intraluminal space, which leads to development of the intraluminal endoscopic lumbar discectomy. Fortunately, since the ligament flavum and nerve here, because that the ligament flavum splitting and the annulus sealing, like this annulus sealing, among structure spacing in intraluminal approach, the structural preservation process that the transfemoral approach seeks to pursue have become possible. Since the intraluminal endoscopic lumbar discectomy started with the ligament flavum resection, we heard a talk about it as similar to open surgery in the early days. However, since then, ligament flavum splitting and annular sealing technique have been introduced, and now a minimized option structural preservation process is possible, similar to the transfemoral endoscopic lumbar discectomy. In addition, as the approach skill become familiar, the working channel can be directly accessed to the ligamentum flavum of the surgical field. So the actual surgical time requires can be significantly reduced. Ligament flavum splitting can target the axilla and the shoulder of the nerve root. Also, compared to the shoulder, axilla has a lot of advantage in the procedure. So it is recommended to split axilla as a target if possible. It is recommended to perform fissure fragmentectomy in order to sufficiently preserve the annulus in the process of removing the protruded disc. You can see here. And also for already made fissure, annular sealing can be performed by shrinkage around the fissure through radiofrequency ablation. And finally, the surgery is over when we confirm the nerve root that were pressed are free. Let's look at the L5S intraluminal endoscopic lumbar discectomy cases. Structural preservation intraluminal endoscopic. Sorry, video not play. Yes, structural preservation intraluminal endoscopic lumbar discectomy can be effectively performed even in severe disc protrusion, as in these cases. When bilateral disc pathology needed management is required, a ventral dural approach can be used to effectively resolve these bilateral lesions. If the pathology disc located in the on the shoulder area, it can be effectively solved by using the shoulder approach. You can see here, and also this case showing the recurrence after intraluminal endoscopic lumbar discectomy. In these cases, we can also solve this problem through the existing fissure. You can see here. L5S foraminal to superior migration HMP is a relatively difficult site for endoscopic discectomy, and the use of contralateral intraminal approach, you can see the contralateral approach, we can effectively resolve these regions. The intraminal approach seems difficult for recurrent disc generated after undergone open lumbar discectomy due to adhesion. But if we enter between the bony structures and adhesion tissue after first approaching the bony landmark lamina, the region can be resolved relatively easily, you can see. And now, discectomy now possible for almost all lumbar disc pathology, and through this, more than 95% of good to excellent clinical results can obtain. Now let's talk about endoscopic decompressive surgery. With the development of surgical instrument, endoscopic spine surgery, which remained in endoscopic discectomy, it became possible to endoscopic decompression. And now most of the spine pathology requiring decompression by using this over-the-top outside-in approach can be resolved through endoscopic spine surgery. Compared to the existing open surgery, endoscopic decompressive surgery has the advantage of like this mobile and angled approach is possible, and access to deeper area can possible, and a clear surgical field of view because it is a fluid-based surgery. Based on these advantages, endoscopic decompressive surgery has become possible to increase the normal life activity through sufficient neural decompression, preserve the functional segments, minimizing the spinal muscle damage, and less neural retractive, which decompressive spinal surgery has thought. In order to effectively perform endoscopic decompressive surgery, thick, larger endoscopic working portal is required, and a more powerful drill system for hard tissue management, and more powerful radio frequency ablation system for soft tissue management needed. The development of this surgical instrument has enabled sufficient bilateral decompression through a unilateral approach under the over-the-top outside-in approach. In addition to these advantages, a simple change in the working portal has enabled sufficient decompression from ipsilateral to contralateral lateralis foramen and extraforamen. These changes have made a leap forward to significantly reduce post-operative instability as well as sufficient decompression, which was difficult part of existing open surgery and can operate to the contralateral foramen to extraforamen. This leap forward development of endoscopic decompressive surgery can be said to be the optimal treatment for the healthy age of 100 years, since it is possible to effectively resolve region while minimizing surgery-related complication even in severe spinal stress like this 80-year-old, in the elderly like this patient you can see here. In addition, using intraluminal contralateral endoscopic lumbar discectomy and foraminotomy, it was possible to solve almost all regions requires spinal lobe decompression while minimizing instability, thus obtaining opportunity to minimize the spinal fusion surgery you can see here. In particular, an increase in the number of elderly patients in inevitably accompanied by degenerative deformity accompanied by spinal stenosis. Even in these cases, decompressive surgery become possible while minimizing fusion surgery. You can see here, this patient followed more than 2 years. Endoscopic decompressive surgery is now also applied to the thoracic spine like this thoracic decompression. And in particular, it is effectively used in the discal pathology that occupied most of the cervical spine also can possible. And with this advancement of endoscopic spine surgery, the era of endoscopic fusion surgery is now possible. In conclusion, endoscopic spine surgery is now positioned as the mainstream of the spinal surgery, and a lot of research and education being conducted. But however, if endoscopic spine surgery truly wants to be at the top of the spinal treatment, we should always keep in mind the ultimate purpose of the pursuit of endoscopic spine surgery. Additionally, if we develop more advanced technology and minimize the inevitable complication in the endoscopic spine surgery, it should be possible to provide better treatment to the patient. Thank you for your kind attention. Thank you so much.
Thank you, Kim. I think it was an excellent presentation. Do we have any questions?
I think there are 2 questions in the
There's
in
a
the chat
question
section.
in the chat. Do you
In the
infiltrate
chat
local
section.
anesthesia in and around the annulus, Kim?
From good to everyone, dear Dr. Kim, how can you scope with dural tears?
Kim, can you hear me?
Kim, Dr. Kim, do you hear us?
I don't think he can hear us.
Kim is not there.
He's there, but he's unable to listen to us, I think.
Okay, I can.
Yeah.
Sorry, maybe I think that
Salman,
maybe the
go on.
connection.
Yeah. Salman.
So, yes, the question is, do you infiltrate local anesthesia in and around the annulus?
Maybe before time, I'm also use the local anesthesia for the transforaminal endoscopic lumbectomy, but I don't use the local anesthesia nowadays because sometimes the local anesthesia is give us some nervous state to the patient and some pain to the patient. Because of that, nowadays I use some epidural sedation anesthesia that is more comfortable to the patient. But if you hope to use the local anesthesia, some local infiltration into the transforaminal is sufficient to decreasing the pain. But maybe during annular penetration, it makes some pain. Because of that, you should caution to the patient that can decrease the pain during the procedures.
And what about CSF leak? What do you do with patients who develop leak?
CSF leak is some some rare complication in the endoscopic lumbar discectomy, but common complication in endoscopic decompression. Because of that, some approaches some different and dural open some different. But anyway, any kind of dural tear like a transfemoral and intraabdominal and decompression, I'm always use the patch blocking technique. I already published that technique in World Neurosurgery, and using the taco seal, I applied to the dural tear area and blocking that point. And that can. Most important point is that nerve incarceration during the dural tear. That is most serious problem after undetection of the dural tear. Because of that, if you insert the gel form or taco seal between the dural tear, it can preventing the incarceration of the nerve, and it decreasing the after finishing the operation. Usually the CSF leakage did not happen. Salman, you sound is muted.
Sorry, another question is about the reoperation risk. What percentage of patients would require re-surgery?
Maybe reoperation, meaning that it's different in lumbar discectomy and lumbar decompression. But I always recommend that some reoperation is very important, because there is a recurrence. In the endoscopic lumbar discectomy, recurrence is inevitable because it related to the degeneration grade. Because of that, but anyway, there have one another point of the recurrence is biomechanical loading. Because of that, decreasing the early ambulation and the sealing and some decreasing the making the lordosis, it can decrease the early recurrence. And my early recurrence rate of the endoscopic discectomy is less than 5%, less than 5 per every year. And also reoperation cases of endoscopic decompression is less than 1%. But I'm always recommend that the most important point is that decreasing the reoperation in endoscopic decompression is the finishing the cranial detachment of the ligament flavum to the bony structure. That is most important point.
Okay. Mehmet, any more questions?
There is one question from someone in the chat. What is the success rate of paraspinal approach foraminal decompression and its complication rate?
To me or to Professor Salman?
Not to you.
Because yes, transforaminal nowadays so many endoscopic spine surgeons, especially Chinese endoscopic spine surgeon, they performing the transforaminal endoscopic decompression for lateral recess or central stenosis. But I don't know, because I don't like that, and I'm not try that process, because I'm always thinking that the surgical technique is always based on the pathology rather than the approach. Because of that, disc pathology is a disc protrusion, but stenosis pathology is instability and thickening of the ligament flavum. Because of that, only imaging some focal point of the stenosis pathology is not sufficient to the spinal stenosis. Because of that, I like the central decompression rather than the paracentral or transperineal decompression. But in the paper, so many authors, they talk that their success rate is very nice, more than 90%, but they should show that the long-term follow-up result compared to the central endoscopic decompression. I think that maybe it needs some comparative study with the central decompression with the same indication.
Okay. You don't like it. You don't.
Yeah.
Do it.
Yes.
Am I right? Yeah. Good. Thank you a lot. Very nice presentation and very detailed information you have given us.